Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody's doing great. Let's start the second lecture of today for the crash course. Let me share my screen. All right. Okay, let me put it in slideshow. Should be good now. All right, so neuromuscular junction disorder. So this is also going to be a very commonly tested topic to discuss and to know before attempting the real exam. Most likely for MCQ1, but you never know. You might get a station in Nakoski as well, which you're dealing with somebody who feels fatigue or who feels weak. And then it turns out to be one of these neuromuscular junction disorder. So most likely you get cases in MCQ1, less likely to get a case of this in Nakoski. But either way, very commonly tested in MCQ1. Learning objective. So first of all, we need to recognize the phenotype of neuromuscular disorder or junction disease, fatigable weakness without sensory loss. So something that we need to keep in mind that when it comes to neuromuscular junction disorder, it is weakness, has nothing to do with the sensation. It's just weakness, or patient will complain of fatigue or tiredness, okay? So definitely this is going to be one of those topics that you need to have as a differential diagnose or even as a diagnose in Nakoski stations if you're dealing with tiredness and fatigue. But in MCQ1, please remember that we do not have sensory loss when it comes to neuromuscular junction. Then the second most important thing that we need to know in this lecture is to differentiate between these common type of neuromuscular junction, which is myasthenia gravis, Lambert-Eaton syndrome, and botulism. By using reflexes, pupils, autonomic symptoms, and response to exercise. So these are the key characteristic factors that we need to use in order to be able to differentiate whether it is myasthenia gravis, whether it is Lambert or botulism. Select first-line investigation and urgent management for myasthenic crisis, and botulism. Identify high-yield medication triggers, thymic disease, and small cell lung cancer association, which thymic is very commonly associated with myasthenia gravis, and small cell lung cancer is very commonly associated or strongly associated with Lambert-Eaton syndrome. So exam on course sensory exam is normal in neuromuscular junction disorder. Keep that in mind. So the neuromuscular junction where each disease acts. Myasthenia gravis, so there might be a case, they might give you a scenario about someone who meets all the characteristic clinical feature of myasthenia gravis, and then they might ask you, which one of the following is accurate for this condition? So is it postsynaptic AC or acetylcholine receptor, or MuSK, which is muscle specific kinase antibodies dysfunction, which is in most cases it is postsynaptic, will be the question. I doubt it if they ask you about the muscle specific kinase antibody, but they need to know where exactly this, if the junction is the issue, where? Is it postsynaptic, which is the case in myasthenia gravis, or Lambert-Eaton, which is the presynaptic? So if it is a synapse, this is the presynapse and this is the postsynapse. So presynapse is for the Lambert and postsynapse is for the myasthenia gravis. Keep that in mind. And another thing is the exercise and activity. For myasthenia gravis, the activity worsens the weakness. It means the more the patient exercises or become active or walk or do things, the patient gets more weak and fatigued. Lambert 18, usually it actually gets better, not better, but temporarily, the weakness goes away or relieves. Exercise briefly improves the strength. And botulism is toxin blocks presynaptic. So it means the myasthenia gravis is post Lambert 18 and botulism is acting in the presynaptic area. And for the botulism, it is descending paralysis with autonomic sign and symptoms. So it starts from top to bottom, and it goes this way, descending. And autonomic symptoms will be positive. So neuromuscular junction, fatigability, normal sensation. Now, high yield comparison, myasthenia gravis, Lambert 18, and botulism. So weakness. In myasthenia gravis, ocular, bulbar, proximal muscle will be weak. For Lambert 18, usually the face is not going to be affected. Usually they're having weakness in the lower limb, but the proximal muscle. And botulism is going to be somehow like myasthenia gravis. It starts from head and it goes down. Activity, again, it makes it worse in myasthenia gravis, but Lambert 18 and also botulism briefly will improve by activity or exercise. Reflexes, remember, the reason I am doing this comparison because they will be in the scenario. For example, the patient has weakness after work and the reflex is normal. So weakness, this part, after activity, and reflex is normal. So these will be mentioned in the scenario, and based on these features or clues, you should be able to differentiate whether this is Lambert 18 or botulism. Pupils, usually it is going to be, remember, the patient will have diplopia and myasthenia gravis, but pupils will be normal. Pupil will be normal. Usually normal, and it is going to be dilated or poorly reactive on botulism. This makes it a very characteristic finding of botulism that can differentiate it from myasthenia gravis. Why? Because they both affect the eye, but in a different way. Botulism will have dilated pupils, but myasthenia gravis has normal pupils, but the patient has diplopia and the patient has ptosis. So it means myasthenia gravis and botulism both affect the eye, but in a different way. If it is ptosis and diplopia, think about myasthenia gravis. If it's pupil that's dilated and poorly reactive, it is botulism. Okay? Autonomic signs is usually negative in myasthenia gravis, but they are positive in both Lambert 18 and botulism, like dry mouth, like constipation, ileus, urinary retention, all this will be positive in both of them. Association, very, very important. For some reason, they love to test you on this one, that it is associated strongly with thymoma. Any patient with myasthenia gravis, you have to check the chest. It means if you have anyone suspected having of myasthenia gravis, you need to do a chest CT scan to look for what? Thymoma. Okay? And also for somebody who has Lambert 18, you need to do a chest CT scan. For what? Not thymoma, small cell lung cancer. So two things that you need to remember. They might mention, they might not mention it directly. Or they might mention the patient has myasthenia. So they're going to give you all the characteristic feature of the myasthenia gravis. The patient has ptosis. The patient has diplopia. The patient has weakness, usually getting worse after exercise or workout, or at the end of the day, it gets worse. And the patient reflex is normal. So what is the next best step? So the next best step is to rule out thymoma, right? So do chest imaging. Now, they give you another scenario, same thing, Lambert 18, and then they ask you what is the next step. Chest CT scan. Why? To rule out small cell lung cancer. And that's why if you notice, these are bigger in terms of size and from the other one here in this chart. So thymomas, muscle, lung cancer, and this is associated botulism with the food, the wound, infant. If it is infant, it will be honey. RNS decreminate or muscle response get smaller with the exercise. So sometimes they will mention that the patient with myasthenia gravis, after exercise, the muscle gets smaller, or due to activity, the muscle gets smaller or shrinking. So this is decrement. Increment is when the muscle gets bigger, that's going to happen in Lambert Eaton. It's another way to differentiate between myasthenia gravis and Lambert Eaton, and also botulism. So increment is usually in these two conditions, and the smaller of or shrinking of the muscle is in myasthenia gravis. So MCQ1 short notes, pupils are abnormal. If it is abnormal, think about botulism, not myasthenia gravis. I'm just gonna repeat it one more time. Botulism, myasthenia gravis, they affect the eye, but in two different ways. Myasthenia, the patient will have ptosis, the patient will have diplopia, but the pupils are normal. Botulism will affect the pupil and it will be dilated and less reactive. Myasthenia gravis, classic MCCQ1 presentation. So ptosis, diplopia. Weakness worsen with a sustained abgaze. It's another characteristic. But any activity that you do, the weakness get worse. Bulbar symptoms, nasal speech, dysphagia, fatigable chewing, or the patient gets fatigue while chewing. Proximal limb weakness, sensation, and coordination. So proximal limb weakness is part of the myasthenia gravis, but it is the characteristic finding of Lambert Eaton. Okay. And pupil and reflex are remaining normal. This is very important. In both cases, pupils and reflex are normal. Bedside clue improves with the wrist or ice pack test. So sometimes, ice pack test is not confirmatory, but it is supportive. For example, someone who has ptosis, they put some ice cube on the top of the eyelid, and after a few minutes, the patient gets better. And now the patient doesn't have ptosis. So it doesn't confirm the myasthenia gravis, but it supports the diagnosis of myasthenia gravis. And also, if you ask the patient to rest a little bit, and then when he wakes up, he doesn't have ptosis. Why? Because he rested, right? So what happens during activity, the muscle shrinks and the patient gets weak. But in Lambert Eaton, when they exercise or do activity, the muscle gets bigger and larger. When they get larger, they are weak, but not like myasthenia gravis. Myasthenia gravis investigation. So acetylcholine receptor inhibitor, the most common and generalized myasthenia gravis. So they might give you a scenario and they will ask you, what is the first best investigation to be done for this patient? Always the investigation is the lab investigation. I'm talking about lab. Acetylcholine receptor antibody. But what if it is inconclusive, or what if it is not generalized myasthenia gravis, like the face, the eye, the body, the trunk, the proximal muscle at the lower limb? What if it is not a generalized? Or what if the patient is generalized, but the acetylcholine receptor is negative? The next step will be the muscle-specific kinase antibody. Then you go after that. So we don't do that as an initial investigation. We do it as a second best. If the initial, which is the acetylcholine antibody, is inconclusive or normal or doesn't help us with that investigation, then you do this. Or if the patient has bulbar, neck, and respiratory weakness. In that case, I will use the muscle-specific kinase. Now, repetitive stimulation or activity will decrement more than 10%. Even though in the exam they might not ask percentage, but it's not bad to know it. That the muscle size shrinkens more than 10% by activity, okay? And it is supporting neuromuscular junction transmission failure. Single fiber electromyography increase jitter, more sensitive electrodiagnostic test. Now, again, if they give you a scenario and if they're asking you, so I'm going to give you a scenario and I'm going to ask you 3 different questions. So the scenario is that you have a patient and the patient feels tired. And when you check, the patient has ptosis, and also the patient complains from diplopia. And also the patient says when he goes to work, he feels very tired. And it is somehow giving you an idea, probably my patient has myasthenia gravis. So what you do now, the question, this is the same scenario. Now the question is specifically asking you, what is the first best initial investigation? What is the answer? Acetylcholine receptor antibody. Now, if it is negative, what do you do? The next step is muscle-specific kinase antibody. What if the patient has, what if the question is asking you in a different way? What is the most specific or sensitive electrodiagnostic test? So if it is asking you the most specific electrodiagnostic test, then it's going to be the single fiber electromyography, not the acetylcholine, because that's not electrical, right? That's blood. And for if they're asking you, so the myasthenia gravis has been diagnosed. So what is the best next step? The best next step is to do a CT scan or MRI of the chest to rule out thymoma, which is very commonly associated with the myasthenia gravis. Thymoma, do thymectomy. Hydrophonium is rare use now because of the cardiac respiratory. So this is not something that you need to know, because if it is rare, they're not gonna put it in the exam. Treatment of myasthenia gravis. So we treat it symptomatically. And if it is immune issue, we control the immune, rapid rescue, and thymus. So for the symptomatic, pyridostigmine is the first best choice as acetylcholine inhibitor. Improves transmission, immune control. If it is immune issue that cause myasthenia gravis, obviously we are going to add prednisolone, add a steroid-sparing agent if needed. And rapid rescue, if it is very serious, the patient has myasthenia gravis, and it is very acute, very severe, the patient cannot breathe, the patient cannot swallow, and the patient is in ICU or emergency room. So in that case, you don't ask the patient to have this pill and eat it, right? Or swallow it. In that case, you do IVIG or plasma exchange. So for the crisis or for the very emergency case or hot acute case, then you do the crisis. Thymus, thymectomy, required for the thymoma, select acetylcholine receptor plus generalized myasthenia gravis. Avoid triggers. There are certain medication, especially antibiotics, that triggers the myasthenia gravis. What are those medication or antibiotic? Aminoglycosides, like gentamicin. Please remember this, because they will test you on these antibiotics. The patient was taking gentamicin, for example, for UTI or for any reason, then suddenly the patient developed tinnitus and myasthenia gravis. You know that this was the reason, the gentamicin was the reason for myasthenia gravis. Fluoroquinolones, ciprofloxacin, macrolide, like azithromycin, magnesium, beta blocker. So these are the medication and antibiotics that triggers the myasthenia gravis. Myasthenic crisis, respiratory emergency, severe bulbar or respiratory weakness. The patient have weak cough. So these are the clues for respiratory failure, or these are the clue for the myasthenic crisis. If the patient has severe bulbar sign and symptom, or weak cough, dysphagia, or problem with swallowing, difficulty speaking full sentence. So it means the patient is going to go into respiratory arrest. Neck flexor weakness and declining forced vital capacity. So this is something to keep in mind. Forced vital capacity, you need to check. Normal oxygen saturation can be falsely reassuring. Treat precipitants, often infection or medication exposure. Whatever it is, treat that. Area, ICU, monitoring, early intubation if needed. If you know that the patient cannot breathe, the patient cannot eat, so obviously you have to intubate the patient. Serial forced vital capacity to make sure that the patient is not having respiratory arrest, negative respiratory force. Treat IVIG plasma exchange, not oral, pyridoxamine for someone who is in ICU. Always, we don't do oral as much as possible for anyone who is hospitalized. Forget about being in ICU, right? So MCQ1 crisis, stabilized breathing, rapid immunomodulation. Cholinergic toxicity versus myasthenic crisis. So what happens that somebody who is having myasthenia develops cholinergic toxicity. So the feature, let's go about the mechanism, the weakness, the pupils, secretion, GI urinary, and management. So myasthenic crisis, too little effective neuromuscular transmission, and cholinergic toxicity, too much acetylcholine inhibitor, because it is too much, right? The treatment of myasthenic crisis or myasthenia gravis is the acetylcholine. But what if it is too much? It causes cholinergic toxicity. Weakness, bulbar respiratory weakness. In cholinergic, it is going to be weakness with muscarinic symptoms. Pupil will be normal, again, in myasthenic crisis, but meiosis and cholinergic toxicity. Secretion, weak cough, secretion burdens may worsen, but in cholinergic, everything is too much. As opposed to anticholinergic, everything is low, right? The patient will be dry, but the cholinergic, the patient will be wet. So everything is too much. Lacrimation, salivation, sweating, diarrhea, all that. GI and GU usually absent, but here everything again too much. Diarrhea, cramps, urination. Management, ICU, IVIG. And for this one, hold excess drugs, supportive care, and atropine if severe. Exam clue, diarrhea plus salivation plus meiosis, cholinergic toxicity, something that we need to keep in mind. So for medication triggered or worsening myasthenia gravis, remember the MAGIC BB. This mnemonic, just to make it simple to remember, MAGIC BB causes myasthenia gravis. What is MAGIC? M stands for magnesium. A stands for aminoglycosides like gentamicin. G stands for general anesthetic neuromuscular blockers. And I stands for immune checkpoints inhibitor. And C stands for ciprofloxacin, fluoroquinolones, and macrolates. And B stands for beta blocker, and another B stands for botulinum toxin. Now let's talk about Lambert-Eaton syndrome. Lambert-Eaton syndrome is a presynaptic issue, autoantibody against presynaptic type calcium channel, decreased acetylcholine release at the baseline, proximal leg weakness, difficulty rising and climbing stairs. These are going to be the main or chief complaint of the patient, that I cannot go upstairs. I feel weak, especially when I'm sitting in the chair, I cannot wake up. So these are going to be the chief complaint of Lambert-Eaton syndrome. I cannot walk, I cannot go upstairs, I cannot go uphill, I cannot raise from chair, I don't have that power to stand up. These are going to be the main or chief complaint. Reduced reflex that improves after exercise and autonomic symptoms. The patient will have not only this condition, the patient will have the dry mouth, constipation, erectile dysfunction. Strong association, small cell lung cancer. For lumbar 18, the domain, electrophysiology, antibodies, cancer search for symptomatic treatment, and additional options. So high yield is that if the patient is exercising, the muscle size will enlarge. Antibody, for antibody, we PQ type voltage gate calcium channel antibodies. This is the one, as opposed to myasthenia gravis, which is the acetylcholine, right? If that fails, then you move on to muscular specific kinase. Cancer search, chest imaging, and surveillance for small cell lung cancer. What was the associated issue with the myasthenia gravis? Thymoma. Small cell lung cancer with lumbar 18. First symptomatic treatment is amifampridine. Amifampridine is the first symptomatic treatment, increased presynaptic acetylcholine. What is the first best choice for myasthenia gravis? Pyridoxine, right? For that, pyridoxine. Pyridoxine is for the myasthenia gravis. Amifampridine is for the lumbar 18. Additional option would be pyridoxine, IVIG, steroid, plasma exchange, selected cases, or very severe cases. So almost the same treatment, but instead of pyridoxine, which is the first best choice for myasthenia gravis, amifampridine is the first best symptomatic treatment. Constant treatment may improve neurological symptom. All right. Botulism, descending paralysis plus autonomic signs. Toxin blocks presynaptic acetylcholine release. Myasthenia, post-synaptic, lumbar 18, botulism is presynaptic. So usually, in this case, it will be the foodborne, one, iatrogenic, and infantile, infant intestinal colonization. Early cranial neuropathy will be ptosis, diplopia, dysarthria, and dysphagia. So again, the patient will have the same characteristic, except diplopia is not seen in myasthenia gravis. Sorry, dilated pupil. Dilated pupil is not seen in myasthenia gravis. The rest of the finding is the same thing. The only characteristic differential finding is the dilated and poor reactive pupils, distinguished from myasthenia gravis. Symmetric descending weakness may progress to respiratory failure. Do not wait for toxin result before antitoxin. Infantile botulism, usually in any infant that is taking honey before age of 1. But in infantile botulism, the patient, what is the earliest symptom, sign and symptom that may appear in infantile botulism? It will be constipation. Okay? Constipation often appears very early. Poor feeding, weak cry, decreased facial expression, they may happen after constipation. Please remember this. They might ask you. Generalized hypotonia and descending weakness, respiratory monitoring is essential. Prevention, no honey before age of 12. Electrodiagnostic clues. I think we did this for myasthenia gravis. It will decrease more than 10%. And increased fiber, myasthenia gravis, calcium accumulate. So we did this. Algorithm, fatigable weakness, no sensory loss. So here we can, so this is the algorithm. Ocular bulbar, normal pupils, reflex for myasthenia gravis. If it is proximal leg, dry mouth, low frequency, it will be lumbar 18. If it is cranial nerve, like all this plus dilated pupil. All this plus dilated pupil, it is botulism. Use reflex plus pupil, autonomic finding plus split the diagnosis, to display the diagnosis or differentiate the condition. Medication and exposure traps, myasthenia gravis worseners. These are the medication that makes them worse. What was the mnemonic? Magic BB. So aminoglycoside, fluoroquinolones, macrolide, magnesium, beta blocker, neuromuscular blockers. Botulinum exposure, they usually mention the honey for the less than 12 months. For adult, usually homemade or home canned food. One contamination, injection drugs exposure. If it is infant, honey. Cholinergic toxicity is extra pyridoxystatin plus salvation, diarrhea, meiosis, sweating, fasciculation. Lumbar 800 flax, usually for the lumbar 800, they may give you an older smoker, weight loss, dry mouth, and proximal leg weakness. And what will be the chief complaint? I cannot stand up from chair. I cannot go upstairs. I cannot walk uphill. I have problem walking. I don't feel that power anymore. Always ask infection, medication, exposure, food, wound exposure, smoking history. Rapid review, one-line diagnose clue. The clue, ptosis, diplopia, worse with a sustained gaze, normal pupil, myasthenia gravis. As acetylcholine receptor negative, but a strong myasthenia gravis phenotype, what do you do next? Test the muscle-specific kinase antibody. Severe dysphagia, weak cough, low force vital capacity is respiratory failure of myasthenia gravis or myasthenic crisis. Dry mouth, proximal leg weakness, reflexes improves with exercise, lumbar 8. Older smoker with the lumbar 8 phenotype, screen for the small cell lung cancer. Home canned food plus dilated pupils, descending paralyzed, botulism. Constipation, floppy infant after honey is infant botulism. Weakness, salvation, diarrhea, meiosis after pyridoxystatin, cholinergic toxicity. Final MCQ take-home points. The neuromuscular junction disorder causes fatigable weakness without sensory loss. If it has sensation, numbness, this and that, needling, burning, this is not neuromuscular. Myasthenia gravis post-synaptic. Myasthenic crisis, ICU. Serial force vital capacity, IVIG, plasma exchange. Lumbar 8 is presynaptic. Screen for small cell. Botulism is presynaptic. Toxin blocks acetylcholine release, dilated pupil. Infantile prevention, no honey before 12 months of age. This is the short note. I will let you guys have access to that before we start doing some cases. Thank you very much.